Welcome everybody to tonight's webinar, an Immunisation Coalition webinar on this evening's topic, RSV or respiratory syncytial virus or syncytial virus, a 2024 update. My name is Andrew Minton. I'm your moderator tonight. I work for the Immunisation Coalition, and part of my responsibilities is the education program and bringing you education activities, together with my colleague Anastasia Barron, who's doing a lot of work behind the scenes. So firstly, I would just like to talk about the welcome to country. I'd like to acknowledge the traditional custodians of the various lands of which we work and pay my respects to elders past, present and future, and to celebrate the diversity of all Aboriginal peoples and their ongoing cultures and connections to the various lands and waters of Australia. Just a bit of housekeeping. Presenting tonight, we're very lucky to have Dr. Gemma Saravanos, who will be speaking for around about 25 to 30 minutes, which will give us plenty of time for questions. This is a recorded session, so this recording will be available in about a week's time on our website, together with any unanswered questions that we were not able to get to. So that will be sent out to all of those that registered with the link to the recording and those questions that we weren't able to answer. Please type in your questions as per normal in the Q&A. I'll look for those questions and bring those up at the end. But you can also use the chat function. So that's for you to talk to your colleagues or ask questions to your colleagues and peers, but I'll also be looking at some of those comments in the chat to see if I can also bring those up in the question time. Because this is a recorded session, it will automatically be on mute. And to respect everybody's time, we'll be finishing dead on 7 p.m. So before I introduce tonight's speaker, just in 1 minute or 1.5 minutes, I just wanted to bring you a little bit of RSV infection information, and our speaker tonight, Gemma, is going to go through this, so I'm not going to go into any great depth, but year to date, there's been 100,000 laboratory confirmed cases. It's a little bit above that, but that was just a few days ago. That's 1 month ahead of the 2023 season and 2 months ahead of the 2022 season. So RSV infection started early this year. It was around about February, and the curve continues to climb. We don't know where the peak is yet. We're in the middle of, or just towards the end of June, but we'll know where the peak is in a couple of months' time. So if we look back at 2023, there were 75,000 cases year to date, and it peaked in June. In 2022, there were 25,000 cases, only 25,000 cases, which peaked in July. And yes, we are more aware of RSV, and they probably are being reported more so. But just based on those numbers year to date, with RSV starting early, but it's still climbing in May and June, we're 33% higher than we were last year. So that's the problem. That's the bad news. And Gemma's going to go through some of the good news, where we've got some new vaccines available to us. And I did notice on the PBAC minutes recently that one particular vaccine is recommended for NIP listing for maternal use. And we also have an additional monoclonal antibody. So yeah, we went from almost nothing to several options, and this year is kind of a test year as these vaccines and monoclonal antibodies are rolled out, and we'll see what effect they have this year and next year. So without further ado, I'd like now to introduce our presenter. So Dr. Gemma Saravanos is an early career researcher, educator and associate lecturer, and clinician based in the Susan Wakel School of Nursing and Midwifery, University of Sydney. She holds a postdoctoral research fellow appointment at the University of Sydney Children's Hospital and Westmead Clinical School and Centre for Paediatric and Perinatal Infection Research. Gemma's expertise lie in several important areas, of which some include public health surveillance, epidemiology, infection prevention and control, and immunisation and nursing, as Gemma is also a registered nurse. So without further ado, I'd like to hand over to Gemma to take us through her presentation on RSV 2024 update. Thank you, Gemma.
Thank you, Andrew, for that very warm introduction, and good evening, everyone. And thank you for joining us for this update on RSV. I would first also like to acknowledge that I'm presenting from the beautiful lands of the Gadigal people of the Eora Nations this evening, and I extend my respect to all First Nations people and acknowledge their strength, resilience, and continuing connection to country. It has been my privilege to work with the Immunisation Coalition for the past few years to bring you the latest on RSV disease, surveillance and prevention. This is the first webinar that I've been involved in where I can say that we now have safe, effective immunisation for RSV prevention. And the focus, as you can see in the learning outcomes here today, will be on current RSV surveillance and immunisation, particularly in the Australian context. The last 5 years has seen big developments in RSV prevention, and this year has delivered some significant milestones. So I've given this presentation the subtitle, RSV Prevention, Where Are We Now? We'll touch briefly on the burden of disease, and we will look to the National Notifiable Diseases Surveillance System data. We'll discuss current passive and active immunisation approaches and target groups, and that focus again here on their delivery in the Australian setting. We'll also talk about public awareness and attitudes surrounding RSV and immunisation, and my aim is that the information presented tonight will bring you up to speed with where we are now with regards to RSV prevention, and hopefully get you thinking about your current and potential future role in RSV prevention. So the first really important point to make about the burden of disease, and I'm sure that this audience is very well aware of this, this is a disease that predominantly affects those at the extremes of age. Globally, every year, there are millions of RSV-associated hospitalisations and deaths in children aged less than 5 years and also in older adults. The burden of disease is generally greater compared to influenza disease. This is particularly true in young children, where RSV bronchiolitis is a leading cause of emergency department presentations and hospital admissions. A lesser known fact is this is also true for adults in most seasons. RSV death does occur. Mostly this is in low resource settings and at-risk groups. Hospitalisations and ED presentations are largely driven by acute lower respiratory infections, so bronchiolitis and pneumonia, but we do also see exacerbation of chronic conditions, particularly cardiopulmonary conditions, and occasionally also extrapulmonary presentations such as seizures occur. Community disease is less well characterised and may include acute lower respiratory infections, upper respiratory infections, and otitis media being some of the more common presentations that you would see. There are a range of other important impacts associated with RSV disease that you may or may not have considered. There's mounting evidence that early RSV infection can cause later onset asthma. A birth cohort study of healthy infants found that that infant RSV infection contributed to around 15% of asthma at 5 years of age. There's also evidence that, like influenza, RSV infection can trigger cardiovascular events such as myocardial infarction and heart failure in adults. There are quality of life impacts, which might be related to symptoms of the RSV disease, disruption to normal activities, and anxiety or stress in caring for a sick child. RSV infection is a big driver of healthcare resource consumption, pressures and costs. The winter surge we often talk about of respiratory illness is a well-recognised phenomenon and causes substantial pressures on our health system. In some cases, there is an overuse of low-value interventions, particularly this has been recognised in bronchiolitis, and sometimes also an overuse of antibiotics. Within the healthcare system, healthcare-associated RSV infections also have an important impact. We have good overall evidence of RSV disease burden. However, there are still gaps in population groups where more research is needed. And here I'm sharing some results of a recent scoping review that looked at burden of disease in Australia and New Zealand, looking at all of the studies that exist, really highlighting that most studies focused on young children in a hospital setting, as we would expect. But studies examining the burden of disease in adults and in primary care settings were less common. There's also limited description of the economic burden and no studies that have quantified indirect or social costs associated with RSV disease. So now we're going to look at national RSV surveillance in Australia, and I personally think this is very exciting alongside our new RSV immunisation that has just come in recently. So RSV was made a nationally notifiable disease back in 2021, but implementation predominantly occurring in 2022. So we're really starting to see the results of this now. As of the 19th of June, there were over 100,000 notifications nationally, as reported by Andrew earlier. So a really big number. This figure here on the screen shows the 2024 notifications data by age group and sex. And you can see that predominance of notifications coming from that, under 5-year-old age group, those young children, and with a slightly higher predominance in males. And this is as we would expect. The table here on the right shows the breakdown by state and territory, with about 48% of these coming from New South Wales, so almost half. So just highlighting here that these raw testing numbers are affected by population size, seasonal differences and testing behaviours. So we do need to keep that in mind when we look at these data. Recently, these national data have been collated and included in a respiratory surveillance report published by the Australian Government under the banner of the Australian Centre for Disease Control. And this is supporting near real-time monitoring and communication of epidemics like RSV. The epicurve here shows the number of RSV cases by week nationally and suggests that we may have just passed the peak of disease, noting that there is variation at the state and territory level. So in particular in Western Australia, which has seen very few RSV cases to date. This report also gives us a breakdown by age and population rate and provides comparisons to COVID and flu. Noting again here, though, that potential for these rates to be affected by testing variants. We know that historically younger people, children, are more likely to be tested for RSV compared to adults. We look at that top row there, our under 5s again, you can see the rates for RSV over 3,000 per 100,000 in this group. And that's much higher compared to COVID and influenza. For older adults, the rates are somewhat comparable with flu. COVID is notably higher here. There is a good case for respiratory pathogen testing if it is available to you in your practice. Due to overlapping symptomatology of common respiratory infections, as you can see in the figure on the right here, a laboratory test is really the only way to accurately discriminate between viral causes. While it's not always critical for clinical management, testing does confer some individual and population level benefits. And these include supporting accurate surveillance and disease burden estimates, supporting vaccine effectiveness studies, in some cases guiding clinical management, so particularly thinking about antivirals for flu or COVID. Other benefits may include reduced interventions, reduction in antibiotic use has been suggested, and potentially also increased awareness of particular pathogens and particular severe respiratory infections as well. There is, however, a real need for evidence-based clinical guidelines to support us with our testing practice. So now we're going to look at the current RSV immunisation landscape. So I'll start looking at the big picture, and then we'll drill down and head to Australia and talk about what's happening here now. So as I think you would all be aware, again here, there is a really rich RSV immunisation landscape, over 30 candidates in clinical or preclinical development, and this has been guided by over 60 years of research. In children, current approaches include passive immunisation with monoclonal antibodies, as well as active vaccination with live attenuated virus vaccines, nucleic acid-based vaccines, recombinant vector vaccines. When we look at the maternal population, active vaccination of mothers in pregnancy to protect their babies via a passive transfer of antibodies continues to be a favoured approach. And our products here include protein-based and nucleic acid-based vaccines. In older adults, protein-based nucleic acid and recombinant vector vaccines are the most common approaches. And just here, highlighting in the images at the bottom, so on the left-hand side, you can see the RSV, or a depiction of what the RSV virus itself looks like. If you can see those little green protrusions, so that's the F, or the fusion protein, which is highly conserved and is the most common target for vaccine and monoclonal antibody products. Specifically there on the right, targeting the pre-fusion protein. So that's before the virus is actually fused with the cell. And that's really demonstrated quite a lot of success for many of these products. So this is a high-level snapshot from PATH of all of the RSV preventatives, including 5 that have achieved market approval. And you'll note there that they cover the 3 population groups. So we've got older adults, pregnant women, and infants. So now we're going to take a look into a real-world example of implementation. Specifically, we're going to look at nirsevimab, which is a monoclonal antibody targeting protection in infants and young children. You can see that in the bottom right hand of the table there. The reason we're going to focus on this one is it's been utilised for population level programs in the Northern Hemisphere season, and really some really exciting results that I would like to share with you today. So Galicia in Spain was one of the first regions worldwide to incorporate nirsevimab for universal respiratory syncytial virus prophylaxis in infants into its immunisation program. It ran the campaign from September 2023 to March 2024 for all infants. It incorporated a newborn, a catch-up, and a high-risk approach. They achieved very high coverage, around 90% for the target population, and they've been able to demonstrate real-world effectiveness against RSV, lower respiratory tract infection hospitalisation, which was 82%, and they've estimated a number needed to treat to prevent that outcome was 25. So really exciting results, and a lovely image there from Galicia in Spain of one of the recipients of this immunisation program. So a similar program was rolled out in neighbouring Catalonia, similarly here achieving really great coverage, so over 75% in its first month of implementation. And they also demonstrated, really, really great results and substantial reductions in RSV-associated primary care, hospital and ICU admissions. And you can see the proportions and confidence intervals there, which are really, very, very impressive results. So let's come down to the Southern Hemisphere, where I imagine the majority of our audience is joining from. So RSV immunisation in Australia, where are we now? So this is a summary of RSV immunisation for infants and children in Australia. Palivizumab there in the top row has been approved for certain high-risk groups since 1999. It is effective, but it remains costly and needs monthly dosing intervals. I won't go into detail on this, but the information is there if you want to look at that in more detail. Nirsevimab, under the trade name Beyfortus, is Sanofi Aventis. It's a single-dose monoclonal antibody. So this is the product described in those real-world examples from Spain. The target group is newborns and infants up to 24 months of age. It's received TGA approval in November 2023, and we have several state-funded programs, which I'll talk about in a little bit more detail. It's not currently available on private market, and it does have an ATAGI statement, so please do refer to that for further detail. So the next product there I'm going to touch lightly on is Abrezvo. It's made by Pfizer. It's a protein subunit vaccine, and the target group is maternal vaccination to protect infants from birth through up to 6 months of age. It also has TGA approval, currently unfunded, but this might change, of course. This is a fast-moving space. And again, here, ATAGI statement not yet available, but coming soon. So this is a sort of a high-level look of the programs that we have for this season in Australia. So a little bit of variation. So we're just going to go through these one by one and just provide you with some high-level information about these programs. So in New South Wales, for this RSV season 2024, there is a vulnerable babies program. This involves the monoclonal antibody Nirsevimab being delivered to infants and children who are considered at risk, are premature, or are Aboriginal and Torres Strait Islander infants. So we know that these particular infants are around twice as likely to be hospitalised with severe RSV disease. Now, this program is only available through treating hospitals, so it is a very targeted program. Heading over to Western Australia, there is a whole population infant approach here that includes all infants born from 2023 in October, all Aboriginal children born from 2022, and some high-risk infants born from 2022. This program is being delivered through birth hospitals, general practices, Aboriginal medical services, and community health immunisation clinics. And in Queensland, an all-infant approach here, again, that includes all infants born from Feb 2024, offered in birth hospitals, again, with opportunity for catch-up for 8 months to 20 months for high-risk infants in primary care. So this is an image of a gorgeous mum and her bub from Junjua community in the Kimberley, who was among the first families to receive RSV immunisation to protect her bub Sandy in those first few months of life. She's reported that she was extremely proud and really wanted to spread the word that this was available to new parents in the region. And hot off the press in Queensland, the government has reported that the immunisation program has shown so far that no immunised newborns hospitalised for RSV since its launch. And here, drawing your attention to hospitalisations on the figure here in the under 1 year old group, who would have been offered a dose soon after birth. So that's looking at those, the line with the red boxes. You can see there's this decreasing trend of hospitalisations in this group, which is early, but still exciting to see this. So looking at a little bit more of the detail on this monoclonal antibody product or passive immunisation with Nirsevimab, availability is currently limited to specific state-based programs. There are supply limitations, unfortunately, And really, the ATAGI guidance is that populations likely to gain most benefit should be prioritised. Hopefully these things will change and there will be more options. Some other considerations to think about are the risk of severe disease is increased for infants with multiple risk factors and Aboriginal and Torres Strait Islander infants, infants with reduced access to acute care such as remoteness, and potentially considering palivizumab as an alternative product where the child is eligible and that's available to you. We still know this is, as I said, it's a very effective product and it should certainly be used and if it's available, and nirsevimab is not. So these are just some specs on the product here. So it's a single intramuscular injection that provides a long-lasting passive immunisation. So in the first season, the dose is variable, which is an important thing to note. If bub is under 5 kilograms, it's 50 milligrams in 0.5 mils. If bub is 5 kilograms or over, it's a larger dose. It's a 1 mil volume, 100 milligrams in 1 mil. Again, here, second season is a larger dose, so that's 2 mils now, 200 milligrams administered. So something to keep in mind. And I think when you're thinking about timing and getting that immunisation as soon as possible to babies, potentially they're getting, they might need a smaller dose if they're under 5 kilograms, of course, and also thinking about maximising that protection during peak RSV periods. So generally that's March to September in temperate parts of Australia, but there is variability here. So we have evidence that this immunisation product will provide protection for up to at least 5 months, so really protecting infants in those early months of life. With regards to safety and co-administration, it can safely be co-administered with routine vaccinations. It is unlikely to interfere with the active immunisation response, being that it's a completely different product. So that's not considered to be a concern at all. General contraindications, of course, as with all of these products, allergy to product ingredients, and also thinking about recent RSV infection, which isn't a complete contraindication, but it might be. So it's a cold chain vaccine here again, and can be kept at room temperature for a period of time and then discarded. So going to older adults now, so Abrevzo here again. So this is that same product, Pfizer. It's a protein subunit vaccine indicated for adults 60 years and over. It's recently achieved TGA approval. Still some information coming on Abrevzo and clinical guidance from ATAGI as well. So we also have RSV. It's GSK. It's a protein subunit vaccine. And the key difference to note with this one is it has an adjuvant. The target group is adults 60 years and older. It has been TGA approved and it is currently available on the private market. One estimate here, around $280, but that is going to vary depending on where you are. And there is ATAGI advice available for this one as well. And we also have Moderna, which has been submitted and is still under evaluation with the TGA, targeting adults 60 years and over again here, and that's an mRNA vaccine. And we saw a lot of success with these products with our COVID vaccines, so one to watch. So a little bit more detail on RSV here. So here we're looking at our older adults. So the ATAGI recommendation is quite specific. So adults 75 years and older, Aboriginal and Torres Strait Islander people 60 to 74 years. So we know this group of individuals do tend to experience severe RSV at a younger age compared to non-Indigenous people. adults aged 60 to 74 years with medical conditions, and younger adults, so from 60 to 74 years, can consider. Currently, again, just highlighting it, it's currently only available on the private market. It's an adjuvanted recombinant RSV vaccine. It's a single intramuscular injection. Co-administration is acceptable. Potential risk of increased mild to moderate adverse events, just to be mindful of that. But generally, co-administration with routine vaccines is acceptable and recommended in most cases. A little bit more detail on contraindications and storage there. I'm not going to go into more detail there, but I'm going to jump now to abrevsvo. So this product has been TGA approved. Now, noting here, I'm going to be talking about two population groups. Target advice is coming. It will be available soon. This product, the same product, is available for active immunisation of pregnant women between 24 to 36 weeks of gestation, for prevention of RSV disease in their infants from birth through to 6 months of age. And it's also indicated for immunisation of individuals 60 years of age and above. Single intramuscular injection, again, with these similar storage requirements. So there is a lot of discussion going on, and a lot of comparisons about what's the best approach to use, how can we protect the most people and prevent most severe disease. And generally speaking, any TGA-approved product is considered to be safe and effective for the group in which it is indicated. Generally speaking, the best product is the one that is given, that is administered. It's going to depend on what's available, what are the costs involved, and also considering the needs and preferences of your patients. So we really need to be guided by this. So this is a very high-level summary of immunisation products and strategies, and a lot of questions are being asked about whether we should take a seasonal or year-round strategy. Different approaches are being taken in different settings around the world. Monoclonal antibodies or passive immunisation or maternal vaccination. And you can see here, looking at both of those products designed to protect those very young infants, both are resulting in very good vaccine efficacy. There is an argument and pros and cons of each of those approaches. We can also look at the products for adults. So we've got adjuvanted protein-based and mRNA products available or potentially available very soon. And just eyeballing these vaccine effectiveness rates here again, you can see that they're all quite high, overlapping confidence intervals. Just noting here, these vaccine efficacy point estimates, they're not designed to be compared directly, and they do measure slightly different outcomes. So there is variation with the clinical trials and heterogeneity with the seasons and where they're run. So do keep that in mind, and really watch your target for recommendations on these. So getting towards the end now, I want to touch a little bit on education and advocacy. Now, whenever I talk about RSV in Australia, generally I say that we don't have any studies in this area. So I was really excited to find and share with you this study published very recently from Western Australia, and it gathered information from almost 2,000 parents or pregnant or families planning children. And they found that 70 to 90% of these respondents were aware of RSV. Awareness was more likely for current parents, so who already had children, those who were Australian born, and those who were university educated. There was less awareness of RSV association with severe disease, so less people identified that RSV could cause pneumonia. There was really positively a high level of acceptance for maternal vaccines and infant immunisation, and information sources on infectious diseases and immunisation included Dr. Google coming in at the top response, but this did include government websites, thankfully, and also clinicians, with nurses and midwives actually rating really highly for information on infectious diseases and immunisations. And obstetrician and general practitioners, of course, very important there as well. So talking with your patients about RSV and immunisation. So as we've alluded to in that previous slide, that knowledge base is going to be quite different for different population groups. So particularly for new parents who don't have children, they're probably less likely to know what RSV disease is. So really assessing that knowledge base, thinking about tailoring the message to your patient, be opportunistic and remove barriers, whether that's barriers to immunisation or barriers to information. Think about your population group, your patient group, and what their needs might be. Of course, recommend, provide or refer, acknowledge uncertainty, and that might be uncertainty about availability and about benefits and risks. Consider vaccine equity. Vaccine equity is very likely to continue to persist with RSV prevention, both within Australia and globally for some time. And we hope that in time this will improve. And always really important to build that trust and leave the door open to those future conversations. This is my final slide. So just some final thoughts on RSV prevention in our communities, and just some take-home key messages, I guess, is to share information about RSV and immunisation with your patients, to recommend and provide immunisation when you can. Remember, in accordance with the TARGI guidelines, and also reporting those to the Australian Immunisation Register. So make sure your product software is up to date so that you can report that effectively if you are providing it. Really important to report adverse events following immunisation, particularly in these early periods. That post-marketing surveillance is very important. Consider respiratory pathogen testing if it's available to you. Promote basic infection prevention and control for all respiratory infections. And then there's all those other things that you can do, which we know have some benefit in reducing the risk of severe RSV disease and severe respiratory infections generally. Of course, that's things like promoting breastfeeding, promoting cessation of smoking, and really encouraging and promoting routine vaccines, as I'm sure you all do. Interesting to note that they have both specific but also potentially non-specific protective effects. So a flu vaccine shows some evidence, for example, of protecting or reducing the volume of influenza disease. Some evidence for that as well. So lots of great reasons to go out and get vaccinated and recommend to your patients. That is really my closing slide, and just would like to wrap up to say thank you to my many collaborators and colleagues at the Sydney Children's Hospital Network and the University of Sydney. And thank you very much for spending the evening with us, hearing a bit more about RSV and RSV prevention.
Thank you, Gemma. Really fantastic overview. Interesting to see the hospitalisation rate starting to decrease in Queensland with the availability of the new monoclonal antibody, nirsevimab. So early days, as you say, but encouraging, very encouraging. So we do have a lot of questions. We have 20 minutes, so that's good. I'll start off with the first one. Palovizumab, that's been around for a little while now. It's primarily given by pediatricians because those patients are in hospital and at risk of lower respiratory tract infections. So will nirsevimab, given that the dosing and the frequency of dosing is somewhat different to palovizumab, do you think that it'll be administered at primary practice, or do you still think this will be a hospital-based treatment option?
So is the question about palovizumab, sorry, or
nirsevimab? Not palovizumab.
Nirsevimab.
Sorry.
Yeah, so look, I absolutely think there's a big role for primary care to play here. You would have noticed with most of the programs in Australia and the ones reported from Spain, they do have a birth hospital program, but catch-up is really important. And I think just acknowledging that role of primary care in antenatal care and shared general practitioner care as well. So yeah, look, I think there's definitely a place there, but I guess it is about making sure we're capturing all of those different population groups, and that's going to vary depending on the patient group and their setting.
Yes, okay. One here from John. How long after a case of acute RSV should an older patient get the RSV vaccine, and how quickly does the immunity wane?
Two very good questions, and I saw that one early on. Thank you for your question. So I'll answer the second part of the question first. So there's enough information from clinical trials from these products to suggest that protection persists into that second season with reasonably good efficacy. There's a bit of reduction, and that information is available. So that's as far as we have at the moment. So yes, so simple answer, yes, we do have persistent protection into the second season. Not sure for how long yet. With your regards to your question about how long should somebody be vaccinated after the RSV infection, a little bit more difficult for me to answer that one. Certainly, it seems sensible that actually the infection will boost their immunity in some way, and possibly a vaccination, it might not be needed. There might be exceptions to that rule. So I think that's probably one to have a little bit more of a look into without making it probably not a clear recommendation there.
Okay, our next question, we're all looking for a RSV vaccine to be added to the NEP. The question is the government going to fund older adults? And based on, and I've seen some of the other comments here and looking at the PBAC recommendations yesterday, looks like one is coming soon, a Brisvo. So, no, hang on, that's for maternal vaccination. So Arexvy, any comments around Arexvy then?
So look, yeah, great question, and unfortunately, I don't have an answer for that. We just really need to wait and see. Okay. Yeah, and hope. So yes, I yeah.
So will the data from the New South Wales, WA and Queensland with regards to monoclonal antibodies will be published in a journal? Do you know?
Look, absolutely, those the results will be shared in probably many formats, including journal publication through government. So if you jump onto the government websites, they are updating on these in periodically as well. So I guess watch that, and yeah, certainly we will still see some rigorous scientific publication of these results as well.
If a baby was born in late September 2023, does that mean they should have a first or second season dosing? They find it a bit confusing, dosing for the second season and what that means.
Yes, okay, so look, it's a good question, and I think that's another thing that's not very clear with regards to the approach. So the approach does depend on the seasonality where you live. So for example, if we look at the Northern Territory, we often see all-round circulation. So there might be an argument in vaccinating, in those early, that first at birth, I should say. But yeah, it does vary. So with the other programs, the program is sort of set as it is. I don't know if I've answered that question very well. Apologies to our participant and Andrew, but yeah. So the response is it depends on the program that's funded, and it depends on the seasonality of the setting. If it's a more hypothetical question.
Supposing that nirsevimab has 5 to 6 months protection or 6 months protection thereabouts, should we re-administer to the child after that period, 5 to 6 months, since the RSV season has just gone or got started?
So it would only be re-administered if it was indicated and funded under the program. So I guess that's going to vary again as well.
How recent is a recent RSV infection? Not sure
Yep.
what means by that.
Yeah, and so that might be, so in the case of RSV infection, and whether, and I think that sort of pertains to, should we immunise if there's been a recent RSV infection, and what does recent mean? So look, I think this is really an area where clinical guidance is recommended, and really looking to those local recommendations.
Kind of similar question here from Con.
Mm.
After an RSV illness, is there an interval between illness and an RSV
Mm.
vaccine? When should it be given?
Yeah, so again here, there's no clear information I can give to that question, sorry.
Yeah. Just a comment here, Abrezvo, yes, it is approved for maternal vaccination, so for pregnant women. So, so we've confirmed that. Just wondering how long, this is from Bronwyn, just wondering how long Arexvy is effective, 2 seasons or more, and you did touch upon that, I believe.
Yeah, I did. So I think we had another participant asking a similar question. So there's certainly evidence that that protection will persist into the second season with a bit of a reduced vaccine efficacy.
One from Michael here. Good to see you online, Michael. With adults, we have low pneumococcal vaccination rates. Should we prioritize RSV vaccination over pneumococcal vaccination?
Okay, look, fair question. And I think, it's about thinking about how we can optimize our programs and delivery. I mean, I would suggest consider giving both. Co-administration is acceptable. But of course, it does come down to that discussion with your patient, what their preferences and priorities are, and of course, your good advice and recommendation.
So that would also apply for influenza vaccination as well.
Absolutely, and COVID.
Yeah, so I mean, at the moment, it's a bit of a perfect storm. It's a bit of a trifecta. We've got high influenza infections rates. Vaccination rates are decreasing. We've got high COVID rates are increasing, and we've got high RSV rates this year. So it's kind of like a trifecta. Some have peaked, and some we don't know have peaked. But it's a concern for all of us to get as many jabs in arms as possible. So based on that, actually, influenza rates are going down across all age groups. Interestingly, under the 5 as well as the over 65, not so much. Do you see when these vaccines indicated for over 60, when they become NIP listed, that there's also a danger of them falling off in time? What do you think we should do to make sure that doesn't happen?
Do you mean, Andrew, falling off the radar in terms of awareness?
Yes, not being taken up by the public, not seeing RSV as a serious disease, which I think influenza is, and they're just not walking into clinics or pharmacies to be vaccinated.
Yeah. Look, I think that's a really important consideration, and certainly I think it's pretty clear we have a real gap in knowledge and research in the RSV adult space, and I think that's a gap that needs to be filled, and something, of course, we as clinicians can do, with regards to talking to our patients, raising that awareness, saying, RSV is actually associated with just as significant, if not more significant, severe illness compared to flu.
Yes, and we're actively looking and engaging with the public, actually. So we're attacking it from both ends, which is what we should do. What proportion of healthy babies develop severe RSV, lower respiratory tract infections?
Okay, good question. So we've got quite a bit of data on this. It sort of depends on the age group, and I guess the method that you've used to look at this. So I think it is about one, if you put it in smaller numbers, it's about 1 in 50 for infants aged under 3 months will be hospitalised with RSV-associated disease, probably lower respiratory infection, bronchiolitis. And if we look at Aboriginal and Torres Strait Islander infants, it's about 1 in 25.
Okay, well, thank you.
Mm.
It's an interesting one from Sue. An Arexi rep advised us that the efficacy of this vaccine drops to 66% at 18 months post-vaccination. Is a booster recommended? When would that booster, or when would the new vaccination, be administered?
Yeah, yeah. So see, that sounds about right from my recollection as well. So we do see that drop in vaccine efficacy in that second season. So currently there is no booster recommended. It's still considered to have quite good protection, even though the reduction, and that will continue to be monitored to see, well, how long does that persist for, and boosters and things like that will be considered at a later time when we have more information.
Another question from Paul here. At $300 a dose, and for now 2 years effectiveness in older persons, will these make the NIP?
Good question. And I think, just sort of flagging that vaccine equity issue here again, it is quite a big amount of money for somebody to pay. So, yeah, look, it's a good question, and we'll all be watching this space.
This is from Jacqueline, is there any information available on adverse events of RSV vaccines?
Yeah, so absolutely there is. I haven't gone into detail on the presentation this evening, but I do urge you to go away and have a look at the links provided, particularly through the National Centre for Immunisation Research and Surveillance, as well as product information. That's all reported overall, very favourable safety profiles. But that will continue to be monitored in post-marketing studies as well.
Any of the RSV vaccines for infants and older adults going to be on the NIP? Well, so hang on a second. So we already covered Abrezvo for maternal vaccination, and for older adults, well, we have to wait and see, right?
Yeah, that's right. So question we all want the answer to, but unfortunately I don't have the answer to that.
Well, the cost here from Diane, approximate cost privately funded is $300 for 2 doses. Is that correct?
So 1 dose, but only a single dose is recommended, with protection into the second season.
Just trying to look through these questions.
So just clarifying that there. We've got a very healthy volume of questions tonight, Andrew, which is good to see.
Have a long questions. Once RSV infection is confirmed, when is the best time to get the vaccine post-infection? So what's the wait period?
Sorry, can you so is that after a laboratory confirmed RSV infection? Yeah,
Yes.
so we have touched on that already. So it's really not clear at the moment. So I think it's really probably the infection itself is going to boost the immune, give you an immune boost potentially as well, but it is going to depend on the particular the individual and their risks and conditions. So I think that's something to sort of look at the details of the individual and the recommendations as well.
Combined vaccine approach. Any potential for an RSV, influenza, COVID, or any combination of the 3? Do you have any?
Yeah, so look, absolutely further down the pipeline, but with the mRNA products, they are looking at some combination approaches. So COVID and influenza, and also COVID, influenza, and RSV, which I certainly think as a clinician and as a patient is quite a nice idea, isn't it?
Yes.
So another one to watch.
Yes. This is a question from Eleanor. If you've had the symptoms for a few days and thought it was just a cold, is it worth getting tested? Well, there are rat tests now in pharmacy that do RSV, COVID, and influenza A and B. So it's always worth getting tested if you've got the symptoms.
Yeah, look, it can be useful. I really do think, some good clinical guidelines, both for clinical areas, but also for the public as well, are really important, Andrew, because it can be difficult to know. Look, I think if they're available and they're affordable for you, it's always good to have a bit of extra information, and it helps to be able to communicate these things as well. Unfortunately, though, we wouldn't capture those results in our national notifiable diseases surveillance. So that's only if it's an accredited laboratory confirmed disease.
That's right. And those rat tests are available in pharmacies. Shop around between pharmacies because it cost us $7.99 for one, and then we've got another one in another pharmacy, and it was $16.95 for the same test. So
interesting.
Interesting. I've heard that the vaccine probably should not be given with the influenza 65 years and plus. What's your thoughts on
So
that?
was that with the flu vaccine, co-administered with the flu vaccine?
The vaccine probably should not be given with the influenza vaccine that's 65 years older.
Okay, so look, the advice is that it can be given, but there is an increased risk of mostly mild, moderate side effects. So it is something to, to weigh up that risk benefit for that patient.
That is all the questions. In fact,
wow.
We got through most of them. I didn't get to some of them, but we got through most of them. You were a double up on questions, so I skipped some of those. And the time is 6:56, so I think we'll end there. So I think there is one more slide, but thank you very much, Gemma, for giving your talk and your time and your expertise. It was a really fantastic talk, so thank you. And also thank the audience. I'd like to thank the audience for their engagement and their questions. For any questions that we did miss, we will look at those and provide answers and send those out to all of those that registered. And as I said, the slides will be, and the slide and the recording will be available next week on our website. So that's under the IC Immunisation Coalition website under events/webinar. The next webinar is on the 10th of July. It's coming around quick on pneumococcal disease. That's presented by Angela Newbound. So those details are up on our website now, so you might like to register for that. There is an evaluation form that's probably in your inbox already. If you could just take the time, it takes 2 or 3 minutes to fill it out, and it just ensures our future presentations remain as a high quality activity. So with that, I'd like to say thank you to everyone. And Gemma, you might want to say something as well before I sign off.
So just a quick big thank you to Andrew, the Immunisation Coalition, and to our lovely audience participants this evening.
Okay, good night, everyone. Stay well and see you perhaps on the 10th. Thank you.